All right, let's talk about a true medical mystery. One of those classic cases that can stump even the most experienced doctors, the fever of unknown origin. This isn't just about a patient feeling warm, it's a genuine diagnostic quest that turns clinicians into detectives.
So picture this. You have a patient, a 45-year-old, who's been dealing with a spiking fever for 4 straight weeks. You do the initial workup, right? You run the blood work, you get the cultures, you order a chest x-ray, and everything comes back completely, frustratingly normal. No obvious bug, no clear cause. So what's going on? And more importantly, what on earth do you do next?
Here's our game plan for cracking this case. We'll start by defining what a fever of unknown origin, or FUO, actually is. Then we'll line up the usual suspects, the common culprits. After that, we'll walk through the initial investigation, learn how to hunt for clues, and finally, we'll put together the ultimate detective's toolkit. Okay, before we dive in and start ordering a million tests, we need to know the official rules of the game. See, the definition of FUO is really specific. It was designed decades ago to make sure we're focusing our energy on the truly puzzling cases, and not over-investigating every single fever that hangs around for a while. This is the classic definition, the one from Petersdorf and Beeson. Let's break it down, because every part is important. First, the fever has to be legit, at least 101 degrees Fahrenheit. Second, it's got to be persistent, lasting for more than 3 weeks. And the final piece, which is absolutely critical, is that it only gets the label FUO after a solid initial workup has failed to find the cause. So just think of it like 4 boxes you have to check. You need that significant fever, you need that long duration, the patient can't be known to be immunocompromised, that's a whole different category. And, again, the initial round of standard tests has to come up empty. Only when you've hit all 4 of these points do you officially have a case of classic FUO on your hands.
All right, the case is officially defined. It's time to do what any good detective would do. Let's line up the usual suspects. What kind of things actually cause an FUO? Well, they tend to fall into a few big categories.
Most of the time, the answer is hiding in one of 3 main buckets. The first is infections. But we're not talking about a simple strep throat, we're hunting for hidden infections. Things like a deep abscess somewhere, tuberculosis, or endocarditis, which is an infection on the heart valves. The second bucket is neoplasms, or cancers, especially lymphomas. And the third major group is non-infectious inflammatory diseases. Think rheumatologic conditions like Still's disease or vasculitis. And yeah, that last box, undiagnosed, that's a big one, representing all the cases that, even after everything, remain a complete mystery. So, how do we start sifting through that long list of suspects? Well, every investigation has to start somewhere, and in this case, it's with what we call the obligatory investigation. This is the standard, first-pass workup that you have to do before you can even call it an FUO. Think of this initial panel as casting a very wide net. We're trying to catch the common stuff, right? We check for general inflammation with an ESR and CRP. We get multiple sets of blood and urine cultures to hunt for bacteria. We check on the organs with liver and kidney function tests. Basic imaging like a chest x-ray and an abdominal ultrasound are in there to look for obvious abscesses or tumors. And of course, we screen for TB. It's only if this whole checklist comes back negative that we get to move on. Okay, so that initial workup, it came back negative. We officially have a true FUO. Now the real detective work begins. The strategy totally shifts. We're done casting wide nets. Now it's about a targeted hunt for specific leads. It's time to follow the clues.
From this point forward, our entire investigation is driven by one single goal: finding potentially diagnostic clues, or PDCs. So what's a PDC? It's any little sign, symptom, or lab abnormality that points you in a certain direction. It could be anything: a new heart murmur, a slightly swollen lymph node, a subtle travel detail from the patient's history that you missed the first time.
And where do you find these all-important clues? Well, not always in a fancy, expensive scanner. This quote right here gets at a really profound truth. Your most valuable tool is almost always a super detailed and often repeated history and physical exam. You have to keep going back to the patient, keep talking, keep examining, because clues that weren't there a week ago might just show up today. You can actually boil this whole process down into a simple, elegant 3-step algorithm. Step 1, you hunt systematically for those PDCs. Go back over everything with a fine-tooth comb. Step 2, if you find a clue, you follow that lead. You do targeted testing based on that clue. But what if you find nothing, no clues at all?
That's when you go to step 3, and you bring out the bigger guns, the broader imaging to try and find a clue for you.
So this algorithm creates two very different paths. If you have a PDC, let's say you find an enlarged lymph node, your investigation becomes incredibly focused. You can go straight for a biopsy of that node. It's precise. But if you have 0 PDCs, just an isolated fever, well, now your investigation is a broad search. You'll use something like a CT or a PET scan, not necessarily to find the final answer, but just to find a starting point, to uncover a clue that you can then follow.
Now, there's one major can't-miss exception to this, and it's for patients over the age of 55 who don't have any other clues. In this group, you absolutely have to consider something called giant cell arteritis. It's a type of vasculitis, and it's a common, serious but very treatable cause of FUO in older adults. So often we will go straight to a temporal artery biopsy. It's a classic, don't you dare miss it diagnosis.
So we've defined the case, we've lined up the suspects, we've walked through the algorithm. Now let's just put it all together. What are the essential tools and the core principles you need to tackle a fever of unknown origin?
First, be systematic. Don't just throw a bunch of random tests at the wall. Follow the algorithm. Second, never forget the fundamentals. Your history and physical exam are your superpowers here. Third, be persistent. Go back and re-examine the patient often because the story can change. Fourth, let the clues guide you. Once you find a PDC, let that drive your next move. And finally, you have to trust the process, even when it feels like you're hitting a dead end.
And that brings us to the most humbling part of this entire story. Because after all of that meticulous, brilliant detective work, in up to half of all cases, we never actually find a definitive diagnosis. The fever just goes away, and everyone is left with this lingering mystery.
And that reality, it really forces us to ask a pretty deep question. What is the true goal of an FUO workup? Is it just about slapping a neat label on the chart? Or is the real victory in the process itself? In systematically and confidently ruling out all the dangerous treatable stuff and then helping our patients navigate that uncertainty together. And that, right there, is the art and the challenge of medicine.